Hello and welcome to our recorded outbreak series. The IPAC Hub at the Thunder Bay District Health Unit is an education-focused team whose main goal is to support our congregate living settings in infection prevention and control, which includes managing outbreaks. Module 3 will discuss preventing and controlling outbreaks in congregate living settings which are not long-term care or retirement homes. Make sure to take your time completing this module and feel free to pause when needed, as this is a pre-recorded session. To reiterate, this module is specific to outbreak prevention and control measures for congregate living settings that are not either long-term care or retirement homes. If you are looking for information relating to long-term care or retirement homes, please go to modules 1 or 2. This module will provide an overview on outbreak preparedness, identifying and testing for various illnesses, tracking and reporting, and IPAC measures to manage illness within facilities. We will try to give a quick overview of what you can do, what to look out for, challenges, and how to access assistance with them. The objectives of this module are that by the end, participants will be able to confidently prepare for and identify outbreaks early, understand the reporting requirements for congregate living settings that are not long-term care or retirement homes, implement infection prevention and control outbreak measures to mitigate and prevent further spread. Here is a quick breakdown of some of the acronyms we use in infection prevention and control. Please take your time looking over these acronyms. Colder weather with heavy rain or snow brings everyone indoors, as people spend more time in close quarters, and especially in facilities with common sleeping and eating areas. It is easier for disease to spread from one person to another. This, combined with many residents in congregate living settings having lowered immunity due to age or health, means we usually see a spike in illness at this time of year. In the past, we've referred to this time period as flu season. However, there are multiple other diseases that spike during this time as well. Preparedness is key. We can all appreciate that preparation and prevention are our first tools in controlling disease outbreaks. Having a prevention plan allows staff to understand and implement processes quickly, efficiently, and under less stress. Some ways we can prepare ahead of time are as follows. Policies and procedures need to be updated. This should be done at least annually to ensure no changes have occurred. During the pandemic, we were updating much more frequently, but thankfully we are now trying to transition to a plan ahead approach. Being here today and being a part of our IPAC community of practice helps keep your facilities, policies, and procedures up to date. All necessary supplies should be accessible and readily available for residents on precautions or an outbreak. Most folks have a good grasp on the importance of initiating protective measures quickly in order to stop or reduce spread within their facilities. Having PPE available to deploy immediately when needed will drastically help. Having a process in place to ensure PPE is not expired is also ideal, and ensuring that signage is up to date, printed, and in protective covers so it can quickly be put in place. Ensure staff involved are educated on case management changes. Case and contact management has changed a great deal over the last 5 years, and differentiating between diseases is something many of our facilities haven't dealt with yet. Ensure anyone in this role understands but also feels comfortable and supported to reach out with questions or for help. You also want to make sure immunization records are current. This could affect who is allowed to work, where they can work, and if additional measures are required. Immunizations are often a part of a facility's policies and procedures. And lastly, but probably most importantly, is ongoing IPAC education for staff, even if it feels mundane. Many people want to forget they are burnt out or there are new staff who may not have a lot of exposure or experience. Routine education will ensure these measures are adhered to and good habits are created. The province has created an IPAC preparedness checklist for congregate living settings, which is excellent to ensure you are prepared.
Part of preparing ahead and recognizing cases early is routine monitoring of symptoms. Typically, they can all present in similar ways, and clients should be monitored at least once daily. Common symptoms of someone with illness can include one or more of the following: fever, abnormal temperature or chills, a new or worsening cough, shortness of breath, runny nose, congestion or sneezing, sore throat or difficulty swallowing, generalized fatigue or tiredness beyond normal, muscle aches or joint pain, gastrointestinal symptoms such as nausea, vomiting, diarrhea, or abdominal pain, unexplained headache, and lack of appetite. Case definitions help to determine if there is a potential for a transmissible infection to be at play. The definition includes one of the following symptoms being present: new or worsening cough or shortness of breath, and often fever. Some clients may not produce a high fever depending on their immune system. Or if a client is experiencing cough or fever and one of the following: runny nose or nasal congestion, sore throat, or muscle aches or pains. These can be indicative of infectious illness and will prompt further investigation and measures. For enteric or gastrointestinal infections, the case definition is a new onset of two or more episodes of vomiting or diarrhea or watery stools within 24 hours, or if a client is experiencing new onset of both one or more episodes of vomiting and one or more episodes of diarrhea or watery stools within 24 hours. So this brings us to testing. Any client exhibiting symptoms from the previous slide should be identified as possibly having a transmissible disease. They should be kept away from well clients and placed on additional precautions. As per ministry guidelines, testing should be done on those residents with symptoms. Testing should be offered to these individuals if possible, as they are still residing within a highest risk congregate living setting. For respiratory illnesses, PCR testing is still the preferred method, but a rapid antigen test or RAT test may be your only option if you do not have access to a healthcare provider to order testing. The results, positive or negative, of a rapid test should not change the management plan for a symptomatic resident. RATs only test for COVID, so there are multiple respiratory illnesses which a RAT will not detect. If you are able to have lab testing done, there are some specific requirements from the Public Health Lab, or PHL. The first four symptomatic residents are to have a multiplex panel, or MRVP, testing done, which will identify a range of different potential infections. Any additional symptomatic residents would qualify for fluvid testing if they are eligible for treatment with antivirals. Fluvid identifies those illnesses which can be treated with antivirals, such as COVID and influenza. Depending on your setting, you may also not receive reports of a specific infection unless the resident consents to this being shared. Follow general isolation precautions and don't hesitate to reach out to the IPAC Hub or the Infectious Disease Department at the Thunder Bay District Health Unit for advice or clarification. As with respiratory illness, any resident with enteric symptoms should be identified as possibly being infectious. They should be kept away from well clients and placed on additional precautions. If you have a healthcare provider available to order it, testing should be offered to these individuals as they are still residing within a highest risk congregate living setting. Kits for testing are available through the health unit with specific instructions for collection of samples. The health unit can also provide support in case environmental testing, specifically for food preparation areas, may be needed.
Having done the surveillance, wellness checks, and monitoring, you now have identified there's an abnormal amount of clients who are ill within a short period of time. So what does that mean and how do you handle it? As we already know, early detection is critical. Always being aware of clients' wellness during the winter months is ideal to identify any illness or potential outbreak situation. The earlier you detect it, the earlier you can stop it from spreading. Surveillance or wellness checks should be a part of our routine practice so staff can identify early and report it early. The staff should know who they need to report it to, who that designated staff member is. The designated staff member will utilize a line list to help them visualize and determine if there's an outbreak. Even if it isn't within a small home with a few clients, utilizing a line list ensures the important information is collected to help make those decisions and also helps us here at the health unit to make those decisions with you. So, what is a line list? A line list is a table that summarizes information about cases and illness within the facility. There should be only one main line list to ensure consistency. You don't want to see every shift having a different line list or every person utilizing a different one. There should be one master list that everyone contributes to. So, anyone with symptoms which are not normal to them should be added to that list. You don't need to have a lab test to confirming an illness to put you on there. You just need those symptoms. However, if tests are taken, they should also be added to the line list. If you're keeping a staff line list, that should be separate from the residence line list. We don't want them mixed up together. And staff line lists aren't necessarily required unless you need to use them with your facility. So resident cases will determine if there's an outbreak, while the staff list just assists internal management. So here's an example of a line list. This one states that it's for residents or clients and for a respiratory outbreak. So it's already going to be populated with symptoms that they could be attributing to illness, and also leave space for other if you need to add something else on there. There's really important information that's captured on here. An outbreak number that may not apply to your facility, but again, the date that you're going to report it, who your contact person is, maybe how to reach that contact person. This is a generalized form that is used by long-term care homes and retirement homes, so there likely will be some information here that won't be applicable to you, but just filling it out to the best of your ability, it still provides that visual, organized view of the situation that is occurring. So, if any specimens are collected for testing, such as a rat test, a PCR test, or a stool specimen, it's really important to put those dates on the list there too, because that can assist when we're looking at dates and declaring uh, a l- an outbreak over or how long they have to be on additional precautions for. For the next part of the presentation, we're going to discuss what steps all facilities should take when there are cases of illness within their facility. So a generalized approach to that. We'll go into how to report any suspected outbreaks to the health unit, how to initiate any additional precautions, how to maintain those line lists, and how to implement control measures to stop the spread and get the outbreak under control quickly. So there is no mandatory declaration of an outbreak for our congregate living settings that are not long-term care and are not retirement homes. So for yourselves who are in shelters and group homes and treatment facilities, we don't need to make the public aware if you're dealing with an outbreak situation. However, you do need to make the health unit aware, as we need to report statistics to the Ministry of Health. Um, and then we can also, when you let us know, support you within that outbreak in any way that you need. We're going to help you manage it and prevent it to spreading to other facilities as well. So what you can do is you can email the IPAC Hub. We're at working hours are Monday to Friday, 8:30 to 4:30. If it is after hours or on weekend, that doesn't mean you're alone. We do have infectious disease nursing staff that are on call for those off hours, and you can reach them through the nurses registry. And they also can provide you any support with those outbreaks during that time. Especially we see maybe during non-working hours, staff that may not be as well versed in IPAC or well versed in outbreaks. So this can be really important to provide this information to staff as well.
A confirmed outbreak in a congregate living setting is defined as two or more clients with a common epidemiological link, each with a positive molecular or rapid antigen test within a 10-day period. You do not have to report until you have 2 cases. However, facilities can still call when there is one and they need support or have questions. It's important to note that with the new provincial guidance, suspect outbreaks no longer exist for congregate living settings. The health unit continues to use that term when monitoring and pending confirmation, as it is still useful. It is also not required to report staff cases to the Thunder Bay District Health Unit. However, still important to monitor and assess the risk any staff cases have posed in your facility and if there is a larger degree of spread or impact to the clients. Again, facilities may still contact the health unit for guidance. To prevent further spread of the infectious agent, it is important to put infection control measures in place. These include both routine practices and additional precautions. Routine practices are based on the premise that all clients are potentially infectious, even when asymptomatic, and that the same safe standards of practice should be used routinely with all clients to prevent exposure to blood, body fluids, secretions, excretions, mucous membranes, non intact skin, or soiled items, and to prevent the spread of microorganisms. Routine practices include hand hygiene and routine use of PPE, but also extend to other elements, such as point of care risk assessment controls of the environment and administrative controls. The consistent and appropriate use of routine practices by all providers and staff with all client encounters will lessen microbial transmission in the congregate living setting and reduce the need for additional precautions. Additional precautions are used in addition to routine practices for any residents known or suspected to be infected or colonized with certain microorganisms to interrupt transmission. So, this would be anyone who is known to have something or who is symptomatic. For an infectious agent or outbreak, the transmission specific control measures will reflect the ways in which the infectious agents can be spread. So, through droplets such as a cough or sneeze, airborne through a CPAP machine or if someone is on oxygen, or contact of an infectious person or their environment. This diagram shows the different routes of transmission of respiratory agents and how they can be spread. Specialized accommodation, signage, and PPE can also be categorized based on the infectious disease, mode of transmission, and terminology we may be more used to hearing. Contact precautions, droplet precautions, and airborne precautions. We have listed the PPE requirements with each of these precautions, and these should be on signage available within your facility. A client is not limited to one of these precautions, as they can be mixed as well. As with COVID, the minimal is droplet and contact precautions. These additional precautions become the minimal requirements, and additional precautions based on a point of care risk assessment could be initiated. If there is increased risk of airborne, then you would use airborne precautions as well. If possible, any symptomatic client should be isolated to their room with the door closed to decrease the spread of droplets within the facility. Food should be delivered by tray service to them, and they should not attend communal dining. If the client is symptomatic, they must remain isolated for at least 5 days after the onset of symptoms or the date that a specimen was collected, whichever is applicable or earlier, and until the case has no fever and symptoms are improving for 24 hours, or in the case of gastrointestinal symptoms for 48 hours. After their 5 or more days, they should mask, if tolerated, within the facility until 10 days from symptom onset. Roommates of the positive case should also mask, if tolerated, for 7 days after their last exposure and be assessed frequently for symptoms. No testing is required unless they become symptomatic. Follow the most up to date ministry guidance relevant to your setting regarding isolation of cases and guidance for close contacts, or reach out to the health unit if you have questions. So these are examples. A client with symptoms or illness will have different isolation rules depending on what kind of other facilities they may attend outside of yours. The rationale for this difference is the risk of spread to other individuals who may have immune system compromise. So this would be a client who lives at a congregate living setting and has a new onset cough with periods of nausea, has had 2 episodes of vomiting on a Sunday. In scenario A, the resident is volunteering off-site at a low-risk organization, a secondhand store. In scenario B, the resident is volunteering at a high-risk organization where they are actively involved with interactions with a high-risk population. In both scenarios, they should remain at home until day 5 and with symptom improvement of 24 hours for their cough and 48 hours with no further episodes of vomiting. Following those 5 days of isolating at home, in scenario A, which is the lower risk situation where they're volunteering at a secondhand store, the resident can stop following isolation guidelines while they are off-site away from home. On returning to their high-risk setting at home, this individual would need to again wear a mask until day 10 following symptom onset. In scenario B, where the resident is volunteering at a high-risk organization, they should either not go to their volunteer commitment, or if they are needed, as we all know that staffing can be difficult, they should maintain masking at all times. In both scenarios, they should remain at home until day 5 with symptom improvement of 24 hours for their cough and 48 hours with no further vomiting.
Resident cohorting is another measure that should be implemented when experiencing an increase in respiratory cases in your facility. It is ideal to have anyone experiencing symptoms to have their own room. Understandably, this isn't always achievable. However, if required, there is a limit of 2 individuals in a room when one of them is ill. Bathrooms should also not be shared between ill and well clients. Assigned bathrooms or the use of commodes can assist in achieving cohorted bathrooms. If it is not possible, then cleaning and disinfecting between the cohorts should be done between each use. We are all aware that not everyone is going to be able to adhere to all the precautions all of the time. Clients within our facilities can be very unique, and we have to work with them in order to follow the protocols the best we can. Clients who are unable to stick to strict additional precautions within their room, especially clients who smoke, have dementia, or struggle with mental health, and those who are known wanderers, can contribute to the spread within the facility if not managed appropriately. The pandemic has assisted in creative thinking in order to balance adherence to measures and life quality. It is always ideal to practice to redirect individuals quickly and efficiently back to their rooms. Ensuring staff have appropriate PPE to protect themselves during these interactions, and there is adequate staffing to support this, especially within facilities where this could be a larger issue. Encouraging those who leave their rooms to at least wear a mask is also an important measure to put in place. If you have clients on precautions, dedicating a safe area for the client away from others in order to give them a break from their room is acceptable. Some examples would be a dedicated smoking area away from those who are well, or one-to-one walks with staff or volunteers, or a sitting area dedicated to that person. It's important to ensure proper high-touch surface environmental cleaning is performed afterwards. Now we have finished discussing symptomatic clients. Let's jump to other IPAC control measures that need to be implemented when there is an increase of cases or an outbreak declared. First and foremost, communication is always key. Ensuring clients and visitors know what to expect is very important. Signage, emails, or phone calls are all ways to communicate this important information. Following this, implementing further measures such as hand hygiene, environmental cleaning, and of course, continuing education on all the IPAC measures with staff, clients, and visitors is important. Teamwork is key during these hectic months. Ensuring everyone is on board will be a big help. Our first and most important IPAC measure will always be hand hygiene. Hand hygiene is a routine practice that must be performed by all staff and visitors, whether they perform direct care or not, and should be encouraged and promoted with residents as well. Effective hand hygiene kills or removes transient bacteria on the skin and can be done by two methods. Hand sanitizing with a 70 to 90% alcohol based hand rub is the preferred method when hands are not visibly soiled. And the second method is hand washing with soap and warm water. The mechanical action of hand washing with soap and warm water is required when your hands are visibly soiled. When it comes to increased cases, any facility should consider the following. Ensure you have an adequate supply of alcohol based hand rub and all other hand hygiene supplies for use during an outbreak. Ensure products are placed in appropriate places throughout the facility for optimal use, such as outside client rooms, break rooms, dining areas, and ensuring that areas that are used only by staff still have alcohol based hand rub available. There should also be someone assigned to refilling the soap dispensers and alcohol based hand rub dispensers. It is important to not run out or have empty containers at any time. If your facility is unable to utilize alcohol based hand rubs from wall units or have it left out, you can use containers kept on person, ensuring staff have easy access to replace those when empty. So, now we're going to discuss some barriers to good hand hygiene. These are some of the lessons that we have learned from the past 5 years, which can contribute to the spread of infections. So, the first is not having sufficient alcohol based hand rub or hand washing sinks readily available. Or there could be a lack of alcohol based hand rub wall units or bottles missing from where they should be, or not having designated hand hygiene locations. This can lead to missed hand hygiene opportunities and increase the spread within a facility. When alcohol based hand rub can't be left out within the facility, some creative solutions previously mentioned may be needed for access. Alcohol based hand rub not in the proper areas or inaccessible to staff. If alcohol based hand rub is hidden in areas not visible to visitors or staff, or there is a lack of signage indicating where to find it, an individual is less likely to seek it out. This leads to missed steps in hand hygiene and just missed hand hygiene opportunities, and this increases the risk of the spread of infections. Another barrier is the misuse of gloves. So, some individuals may use gloves in instances where they are not required or might wear them to replace performing hand hygiene, and this will lead to missing important moments of hand hygiene and contribute to the spread of infection within the facility. Not to mention, it would also be putting the wearer and the other person or client directly at risk of infection. It is very important to have all frontline staff re educated on hand hygiene before respiratory season or when outbreaks are declared. We all know we have to wash our hands, and there's certain moments that we should be washing our hands, but sometimes we benefit from reminders. The same goes for hand hygiene. So we talk, relearn, practice, have signage, and our own type of enforcement around it. Something so simple can prevent life threatening illnesses. Next, we're going to discuss some immunizations. There are some scheduled and some yearly scheduled immunizations that should be promoted with staff and clients in order to prevent case increases and outbreaks within your facilities. Vaccines are available through the health unit, at pharmacies, and with healthcare providers, and many of these places receive their seasonal vaccines ahead of time. The pneumococcal vaccine is available and encouraged for congregate living setting adults that are over the age of 65. The RSV vaccine is recommended for those over 60 who live in long term care or retirement homes, have lowered immunity, are homeless, or are Indigenous, Metis, or Inuit.
Personal protective equipment, or more commonly known as PPE, because otherwise it's a mouthful. So, this is your last protective barrier before you come in contact with any infectious material. So, it's that physical barrier between you, being your skin, open wounds, your respiratory system, mucous membranes, and that infectious material from entering them. So, personal protective equipment includes masks or respirators, eye protection, gloves, and gown. And all facilities have the due diligence that they have to provide anyone who has the potential to come in contact with blood or bodily fluids, secretions, excretions, or non-intact skin to have that appropriate PPE for those staff or volunteers. It has to also be the right fit for you. So not only does it have to be, they have to have adequate supply of PPE, it has to be a fit for you, because with PPE, one size fits most, not always one size fits all. So you might have different sizes and different types of the PPE. What we're going to do is talk a little bit about some lessons learned that we've seen over the years when managing outbreaks or increased illnesses within our facilities. So some things that have increased transmission within the facilities or between facilities even is masking. So when there's respiratory within a home, we want everyone to be, all the staff to be universal masking. And that means you wear a mask at all times. So not just as a personal protective equipment, so not just as PPE. And the difference between that, so if you're already wearing a mask, once you come into contact with someone or you come in contact with that potential, so that ill individual, that's when you want to be taking that mask off and changing it. So it moves from universal to PPE, and then you have to go back to universal. Um, to understand that better, we do have other modules available for learning. There's one on our champions page that's all about the use of PPE, and we go into more specifics on that. But just ensuring that your staff understand the difference between universal masking and masking for PPE and when to change it. One other thing is the use of N95s, ensuring that staff are using them appropriately for when they believe there is a point of care risk to them, as well as having that correct fit. So with N95s, you do need to be fit tested for them to work efficiently. So that's something that should be acquired for your staff. Eye protection, there's some not always understanding of the types of eye protection. So there are different types. There are face shields, there's goggles, and there's safety glasses. The idea of all of them is to protect your eyes or mucous membrane from any transmission, so sprays to the eyes. However, goggles are going to give you that tight seal. So if you're going to have lots of spray and stuff, so that could be maybe bathing a behavioral client who is also very symptomatic. Whereas if you're just, daily cleaning or this extended periods of time within that 6 client's room who's coughing and sneezing, you'd likely just need safety glasses. There would be less exposure to spray. Reprocessing, so eye protection. If you're not discarding of the eye protection after use, it does have to be properly cleaned and disinfected. On our IPAC Hub website, we do have step-by-step instructions how to do that and also how-to videos. So ensuring your staff are properly trained on that. We see misuse of eye protection probably the most because it's the least understood or least used, especially pre-pandemic. Gloves. So a lot of lessons learned we've seen is the misuse of gloves. So staff wearing gloves for activities that don't require them. When you do that, you're likely going to miss your steps for or your moments of hand hygiene. So really want to make sure those not missing those moments of hand hygiene. And when you're wearing those gloves when you're not supposed to, you're more likely to be a super spreader. So touching more things because you feel protected, but you're now not protecting anyone else within the facilities, your clients and your other staff. Examples would be drinking their coffee, typing on their keyboard, using their cell phone. Um, so then they're just going to keep touching all these things, and then they go provide care to a client with their gloves on, or they go touch a common item that someone else might use, and you're missing that step of hand hygiene. Gowns are sometimes misused, so wearing a gown longer than required, moving from room to room, or using them when you're cold as an extra item, or hanging them up to use with the same client later. Gowns, think of them like masks, use them once, throw them out, or think of them as gloves, just use them when you need them and toss them out. There are gowns that can be laundered. Same thing though, instead of throwing it out, you throw it into the laundry bin. Just because they're these ones you can launder doesn't mean you can use them longer. The thought process for many individuals misusing PPE is, again, that they're protecting themselves, but unaware that they're contributing to that spread. So just ensuring your staff, visitors, anyone using PPE has that education and training how to use it. We have a lot of how-to videos on our website, on the IPAC Hub website. Public Health Ontario does. There is no lack of education out there of how to put on PPE or take it off or when to use it. If you need any assistance with that, you can always reach out to us at the Hub, and we're happy to help out with that. We do in-persons, we can do virtual, and we can also provide you with any of that information. So now that we've talked about PPE, let's talk a little bit about the principles of a PPE station. So this is a station that holds all the PPE that you may need for additional precautions when entering that client's room or bathroom or assisting them one-on-one, or providing any direct care. So ideally, PPE stations are set up in storage, so they're ready to be deployed at the first signs and symptoms. So you don't really want to wait for someone to declare an outbreak until you set these up. If a client is experiencing symptoms, those staff members need access to PPE. You don't want a bunch of boxes here and there or in the laundry room or in the storage room. You want it all contained into one area so they visually can see, yes, I need to put PPE on, and all the supplies are right there. So it's not just a accessibility, it's also a visual clue for individuals. PPE stations should be located outside the room of a symptomatic client, because if they are additional precautions, they should be staying in the room. Um, Again, with some of our smaller facilities, that's not always the case. There might be one in the hallway for 3 rooms because all the rooms are really close, but we can get into that a little bit later. So you just need to determine what's suitable for you. Garbage disposal also has to be considered, and we will talk a little bit about that down the way as well. So the setup or arrangement of the station is important. Again, you want to make sure it holds all the necessary equipment. So we're looking at alcohol-based hand rub. So if it's not on a wall where you would set up the station, you want to have that accessible and likely on the top. Gloves. So think about who's utilizing it. You might need to have a couple different sizes of gloves because again, one size doesn't fit all. Masks. What type of mask are required? Is it an N95 or is it a medical procedure mask? Or do you need to have both available for that person doing their own point of care risk assessment? Again, sizes. So depending who's working within the facility, do they have the correct size for their N95 or procedure masks for them? Eye protection. Again, you may have to consider the different levels of eye protection. This may be determined at a facility level or organizational level of the type of care that's being provided. If you are reprocessing, you would definitely want to have some cleaning or disinfecting wipes on site for them. Or it's always great to have them there just for some high touch surface cleaning and disinfecting as well. Gowns, there are different types of gowns. Some are more fluid resistant. So if the cart's set maybe up by a bathroom for showering and bathing purposes, you might want a little bit more water resistant one compared to if you're just providing direct care in a bedroom, you would want a lighter, thinner, not as heavy duty one. Signage is really important. We'll get into that next, and we'll talk about garbage in a bit too. So you want to keep your cart clean, accessible, and organized. The more messy it is, it'll be harder to keep your PPE in a clean manner, and we don't want that to become contaminated. And staff are less likely to be compliant if it is not organized and easy for them to use. You also want to ensure that there's a staff dedicated to restocking the PPE carts. You don't want to wait till you're out of something and standing there and need it, and you need to assist that person, and it could be a timely manner. So you always want to be a little bit ahead on that. And depending on your facility, this may be a couple times a day check, or it might be just once a night check. So signage, we're going to come back to that. It's really important to help control outbreaks and illness within a congregate living setting, and getting in place is crucial. So ideally, we'd like to see you prepared for outbreaks or additional cases by having signage readily available to put up. So we do recommend to have signage laminated or in those protective sleeves, so they're easy to just put up and take down, clean, wipe down what you need. So you're not waiting for someone to print it or find the access to it and then print it. So having these already ready in a binder or with your PPE stations, wherever the easiest for you would be. Now, the signage is important because you need it's really, really important to know the steps of putting on and taking off PPE, because you actually can put yourself at risk of getting sick if you don't take it off in the right order. And putting it on, you want to make sure you're um, protecting yourself correctly. Again, signs should be bright and um, easy to see. So it shouldn't be at waist level, it should be at eye level where you can see the sign, or average eye level. And it shouldn't be cluttered with a lot of other things either. With our smaller homes, you're not going to need the signage on the doors or anything like that necessarily, because you know who's coming in and out of a home. Again, but depending on your facility, you may decide to put signage on your door to indicate to other people that you're experiencing illness. But right now, we're just talking about the PPE signage here. There's also lanyards available that you can wear around your neck if it's not a safety hazard within your facility, for reminders for those staff members utilizing them as well. Okay, so we're going to talk a little bit about PPE station placement and garbage placement. So what you want to do is, when you're taking off your dirty PPE, you want to take it off to the area that it's contained to. So if you're going into an individual's room who's ill and you're assisting with them, ideally you want that garbage just inside that door. And you got to think of your threshold, the doorway, as your clean versus dirty area, or your ill versus well area. Because the person is not feeling well, they should be contained in the room as much as possible. We understand that this is not always feasible depending on behaviorals and clients and home or facility layouts. So the other option is putting it out just outside the threshold. But you don't want the garbage and your PPE station right next to each other. If they have to be on the same wall, they should be separated to keep the clean PPE away from the dirty PPE and any cross contamination. Um, Ideally, you want the garbage as close to the exit of the area you're leaving as possible. So if you need to move something further away, it should be the clean PPE, because when you're putting on clean PPE, you're not putting anyone at risk by walking a little bit further with it on. Now, we've gone into a lot of our facilities to just help them decide, if they were to go into outbreak or when they have been in outbreak, where should we put it? Um, PPE stations as well can be shared by numerous people. You don't need one for each room. So as you can see on here, there's 4 bedrooms and 1 PPE station. So that might be one larger PPE station rather than 4 smaller ones, because you don't need 4 smaller ones. It's not assigned to each client or person. It's just an area where you can access PPE easily. So yes, if you need ever help deciding, you can always contact us at the IPAC Hub, and we're more than happy to come in and assess and assist you with that. So some lessons learned that we have seen with PPE stations. So having inadequate supplies, only having one size of gloves, only having procedural masks, only having reprocessing but nowhere to put your eye protection or to reprocess it. Um, Poor placement would be another one. So down the hall, way out of the way, not knowing who is it for, would be one, as well as garbage in proper placement. So you can see here in the picture that they're right next to each other. If you're not putting the garbage away properly all the way into the bag, it's going to now touch the outside, or potentially even touch some of the clean PPE. And now you're kind of undoing everything you tried to do in the first place. So it has to be a good separation between the two. Ideally, we would say 1 to 3 feet in between, depending on the sizes of the items. So carts, PPE carts, if you're using a drawer system, definitely it's going to be a high touch surface. So you're touching those lots. So it's something you want to add to your cleaning schedule as well. So sometimes that is missed. Signage and proper signage. So either the doffing, the taking off signage is where the PPE station is, and the putting on is where the garbage in. So they've been swapped. So just knowing you need to put the right signs in the right spot. We've seen a lot less of that lately as people utilize it more, understand it more. But something we have seen, or it's a where you stand, you can't see it. So wherever you're standing to put on your PPE, it has to be visual to you. Same thing with taking off your PPE. That sign needs to be visual to you. It can't be across the hall in 12-point font. If it needs to be across the hall, the sign, because that's the only place you can put it, then it needs to be bigger font so those people can see it from that distance. Also with garbage is just overflowing with dirty PPE. Again, you want to contain it, put it down. Ideally, a garbage can with a lid is the most desirable, but not always feasible. So just ensuring that if you are utilizing it is um, appropriate. Also, that you have, if you're using a lot of PPE within your facility or with that client, that it is being changed often so it doesn't overflow at the end as well, because that can end up contaminating more of the environment and then be more on those individuals that have to clean up that area. So speaking of cleaning, let's go into environmental cleaning. This helps break the chain of transmission between the surfaces, which can be reservoirs for infectious agents, and the client, and that's either directly or indirectly through the staff. So it also breaks the transmission between surfaces and staff as well. So you can see on the flow chart here, those red X's indicates where environmental cleaning can help stop that transmission. It is one of the many IPAC measures that can be layered together to provide that safe working and living environment. So environmental cleaning staff, so anyone's doing that, doing the housekeeping, depending what you refer to it in your facility, actually have the ability to infect other clients just as much as an individual who provides care to them. So a facility always should be practicing routine cleaning and disinfecting, especially with their high-touch surfaces. And during outbreaks, you want to make sure those high-touch surfaces are being completed minimally 2 times per day. This is a minimum. So I understand a lot of our facilities are well versed with environmental cleaning, especially since the pandemic, and achieve this more. Um, However, when you are in an outbreak and it does affect your staff, you could have a staff shortage, and you might have to start thinking about um, having extra staff come in if needed to keep up with this. And again, this depends on the size of your facility, your clients, behaviors as well. And typically, if we say minimal twice per day, it doesn't mean you do it before and after breakfast. You kind of want to space that out. Look at doing it after the busiest times, used in communal areas, or during a time when everyone's more quiet or napping, or um, and getting rid of all the germs from the day. So environmental cleaning is a supplement for when hand hygiene steps are missed or a symptomatic individual is within a shared area. So if there's a shared washroom and symptomatic and well individuals are using it, that's going to require some environmental cleaning and more often than twice per day. Um, Again, if you have a client that can't stay within the room when they're not feeling well due to their behaviors, um, that's gonna, and if they're not able to wear a mask, and let's say they have symptoms of coughing, they're going to be spreading their germs more around. Um, and if you miss that moment of hand hygiene yourself, then the environmental cleaning helps reduce that risk of transmission. So we always want to ensure that environmental cleaning staff have personal protective equipment so that they're able to protect themselves. So they need to have access to that at all times, especially if they're cleaning in areas that are being used by ill residents. And they should be properly educated on it as well. So again, you can infect yourself if you're not using PPE properly. So cleaning and disinfecting products are really important. You have to ensure you have the right types of products to kill the agents that you're concerned about. So it's really important you always read the fine print, and that it's also being used correctly. Because if it says you need a 4-minute contact time and you're only doing 2 minutes, well, really, are you doing anything at the end of the day? If you do need some more education on this, we do have a whole module just on environmental cleaning. It goes over labels with you. If you ever have any questions or concerns, you can always reach out to us here at the IPAC Hub, or if you have a public health inspector designated to your facility, you can always reach out to them as well. And they're also very well versed in these products. Next, we're going to talk a little bit about laundry IPAC measures. So all staff handling dirty laundry should use PPE if they feel their hands or clothes could become contaminated. If you're handling soiled linen, so you know it's been soiled with infectious material or potentially infectious material, gloves and gown must be used at that point because you do have that potential of becoming contaminated. In order to prevent spread, try to limit the amount of sorting. You don't want any of those pathogens or the soil to become droplets and into the air that you can inhale or spread onto surfaces around you. Soiled linen should be kept separate from clean linen and laundered separately. And just like environmental staff, ensure that they have training on when and how to use PPE and adequate access to it. But when we're talking about laundry, the most important thing is hand hygiene. So ensure you're washing your hands after contact with dirty laundry or after using gloves when you're handling soiled laundry. And definitely hand hygiene prior to handling any clean laundry. It's the most important tool there, and as you probably have understood with IPAC. So a couple little lessons learned here is the product misuse is the biggest thing, especially when products were maybe more in short supply, and the unfamiliar, like not being familiar with the products. So understand the product you're using, know what you can use it on or what it's used for, ensure that it's the right chemicals. So if you get donations of products, ensure that it's the right thing too. We have had a lot in the past, and sometimes even now, hand sanitizing wipes being provided, but people mistaking them as, oh, they're a sanitizer, so I can also use them on surfaces. So, hand sanitizing wipes are just for your hands and your hands alone. They don't have the proper um, chemicals in order to disinfect a surface or any cleaning properties in them. So you can't use those interchangeably. If they're for hands, they're for hands only, and if they're for surfaces, don't use them as a hand sanitizer wipe either because it can leave a residual or cause chemical burns. Most healthcare grade disinfectants, you want to be wearing gloves when you're using to clean and disinfect with them or washing your hands immediately after. Some procedural errors are an adequate contact time. So again, if it calls for 4 minutes and you're only doing 2 minutes, that means that surface isn't wet long enough for it to kill or deactivate all the germs that are left behind. So ensuring that your staff understand that product that's being used, or if you have contract staff coming in, that they are using the correct things. Inadequate staff to keep up with the cleaning and disinfecting can also be an issue, especially during outbreaks. And then PPE use, extended glove use with laundry. So gloves being worn between dirty and clean laundry, gloves being used for tasks when it's not required, such as sweeping floors or pushing carts. So now you're missing those moments of hand hygiene. So those are the most important ones there.
Additional measures that can be used to help reduce the spread within a facility include, but are not limited to, ensuring clients are educated on guidelines that include not visiting other high-risk facilities unless required, and practicing masking and physical distancing if it is required. Typically, during outbreaks, non-essential visits are asked to be rescheduled. This can also occur when not in outbreak if the measure is beneficial to protect the clients within the facility. An example would be if there is known higher rates of disease within the community. Adding IPAC measures to continue visits is another option as well. Shared items at communal dining, such as salt and pepper shakers or ketchup, should be discouraged, and single-use items should be supplied in place to reduce spread between clients. Ready-to-eat items without a thick peel, for example, apples, muffins, etc., should be wrapped to reduce contact. Increasing hand hygiene in these areas is ideal as well. Always ensure utensils are placed with handles up for self-service. Community activities that are continuing can always be evaluated to make them safer. Consider reducing numbers at events. Reducing numbers allows for more distancing, or if not reduced, consider increasing measures such as masking, airflow, and spacing. Multiple illnesses can occur in a facility at the same time. In the event that two or more illnesses or causative agents are suspected or identified in a facility, each event is managed independently with areas of overlap. There may be minimal differences, but it is still important to differentiate between them if they are known to ensure safety of clients and limit those who might contract both. Influenza may require specifics such as work exclusion and antivirals, while COVID may result in additional measures after additional precautions are lifted. Specific control measures for each pathogen would need to be implemented. For example, cohorting of residents for gastrointestinal symptoms and use of antiviral medication for influenza if indicated, as recommended by the local public health unit and/or the outbreak management team for the setting. So this brings us to the end of our training session. Let's recap what we've covered. Facilities should look at their policies, staff training, and supplies before they have sick residents. Facilities should continue to maintain open communication with health unit staff. Facilities should continue to report multiple symptomatic cases to health unit staff if they are meeting the outbreak criteria or if there are any questions or concerns. Facilities can report an increase or cluster of symptomatic residents to the health unit and should be using some form of line list in order to do so. Additional precautions should be implemented quickly on any symptomatic clients. And we also discussed implementation of other control measures, such as increased hand hygiene, environmental cleaning, and cohorting. Facilities should request additional support if required, such as on-site assistance with organizing PPE carts, staff training and education, support in choosing disinfectants, etc. Facilities in which an outbreak is declared will have additional measures in place. For example, concerning admissions, visitor restrictions, etc. These measures can be determined during outbreak meetings, and health unit staff are here to support. Thank you very much for coming through this entire module. If you do have any questions regarding anything you've learned or anything that you feel was not covered, please contact us at ipachub@tbdhu.com, and we will do our best to provide education and support as you need it.